Welcome to this video in which we shall attempt to make sense out of the alpha blockers. Adrenergic blockers may be classified broadly into receptor blockers and neuron blockers. The receptor blockers may be classified into alpha blockers and beta blockers. Alpha blockers may be classified broadly into non-selective alpha blockers and selective alpha blockers. The non-selective alpha blockers may be classified into two: irreversible and reversible. The example for the irreversible ones is phenoxybenzamine, while the example for reversible non-selective alpha blocker would be phentolamine. Selective alpha blockers are classified broadly into two: selective alpha 1 blockers and selective alpha 2 blockers. Selective alpha 1 blockers are classified into alpha 1A selective blockers and alpha 1 selective blockers. The example for alpha 1 selective blockers include tamsulosin, while the examples for alpha 1 selective include indoramine, doxazosine, alfuzosin, prazosin, and urapidil, of which prazosin is the prototypical drug. Alpha 2 blockers include yohimbine, idaxoxane, and myanserin, and neuron blockers include these, which will be dealt with in a different video. Now, regarding phenoxybenzamine, this is indicated in the preoperative management of pheochromocytoma, which we will deal with in a separate video. Non-selective alpha blockers like phenoxybenzamine and even phentolamine can produce reflex tachycardia. Phentolamine has got some curious indications. Firstly, it is famous to prevent sloughing of surrounding tissue when drugs such as epinephrine, norepinephrine, and dopamine extravasate. It is also used in the treatment of hypertensive crisis due to clonidine withdrawal and during intraoperative pheochromocytoma excision. It is also used for the reversal of intraoral local anesthesia containing a vasoconstrictor in dental practice. There are other indications of phentolamine as well. Now, regarding selective alpha 1 blockers, unlike the non-selective alpha blockers, these do not produce tachycardia. They are used in hypertension, but they are used only as second-line antihypertensive agents. They are not considered as first-line therapy for hypertension. They are not recommended as monotherapy for hypertension. And this is because they are less effective for prevention of cardiovascular disease than other first-line agents. When we use alpha blockers for hypertension, they are usually combined with diuretics, beta blockers, and other antihypertensive agents. In fact, beta blockers enhance the efficacy of alpha 1 blockers. Now, we need to know what are the situations in which selective alpha 1 blockers are preferred in hypertensive patients. Normally, they are considered second-line agents, but when certain comorbidities coexist, then they become preferred drugs in the treatment of hypertension. So, alpha 1 blockers are very useful drugs for hypertensive patients with benign prostatic hyperplasia as well as dyslipidemia. Now, if we take a look at a cut section of the urinary bladder with the urethra, so this would be a coronal section, we would be able to see that the urethra actually pierces the substance of the prostate gland. The prostate gland is seen to invest the urethra. It surrounds the urethra. So, benign enlargement of the prostate gland can cause difficulty in the passage of urine. Selective alpha 1 blockers work in these patients by relaxing the smooth muscle of both the prostate gland and the bladder neck, and their effect is usually seen very quickly within days. In general, alpha blockers provide only symptomatic relief in patients with benign prostatic hyperplasia with difficulty in urination. They generally do not alter the progression of BPH. However, 2 alpha blockers can produce apoptosis of smooth muscles of the prostate gland in addition to smooth muscle relaxation, and these include terazosin and doxazosin. Thus, selective alpha-1 blockers are useful in hypertensive patients with coexistent BPH. Can alpha blockers be given in patients with BPH without coexistent hypertension? The answer is yes. And that's where the alpha-1A selective blockers come in. These include drugs such as tamsulosin. Alpha-1A receptors are seen in the prostate but are absent in the vasculature. The selective alpha-1 blockers have no significant effect on the blood pressure. They are not approved for hypertension but are approved for benign prostatic hyperplasia. Having said that, they do not induce apoptosis of prostatic tissue. Hypertensive patients with BPH will benefit from a long-acting alpha blocker like terazosin or doxazosin. Additionally, the dose of terazosin in both hypertension and BPH are similar. It can be started at a dose of 1 milligram orally at night, and the dose can be slowly up-titrated to up to 20 milligrams per day as per the response of the patient. Now, regarding the role of selective alpha blockers in hypertensive patients with dyslipidemia, alpha-1 blockers reduce the plasma concentrations of triglycerides and total LDL cholesterol. They also increase the HDL cholesterol. However, these effects on serum lipids are very small and the clinical significance is unknown. Hence, they have no value as drugs for the treatment of dyslipidemia as such. But at any rate, they do not worsen dyslipidemia, and these effects make them the preferred drug for hypertensive patients with coexisting dyslipidemia. These potentially favorable effects of alpha-1 blockers on lipids persist, even when a thiazide-type diuretic is given concurrently. We need to know the adverse effects of alpha-1 blockers, both selective and non-selective, and the most notorious adverse effect of alpha-1 blockers include the first dose phenomenon and retrograde ejaculation. Another adverse effect is the floppy iris syndrome. Now, a major precaution regarding the use of alpha-1 blockers for hypertension is the first dose phenomenon. Orthostatic hypotension occurs within 30 to 90 minutes or longer of the initial dose of the drug or after a dose increase. Now, this effect may occur in up to 50% of patients, especially in patients who are already receiving a diuretic. However, after the first few doses, the patients develop a tolerance to this marked hypotensive response.